Welcome everyone who is joining us today for this very first Immune Confident Institute Becoming Immune Confident Member Mastermind and Open House. I am thrilled to welcome my friend, my colleague, my mentor, Dr. Amber Patterson. She is joining us today from Findlay, Ohio, just a couple hours north of here, where she practices general allergy immunology in a solo private practice at Allergy. She is world-renowned in her expertise in allergy immunology, in particular for pioneering the future of immunotherapy. And so as the U.S. ambassador for Intralymphatic Immunotherapy, or ILIT, which we're going to talk all about, it is a 3-injection allergy shot protocol. And she is not just advancing the field, she really, truly is redefining it. As a leader in the field, Dr. Patterson has served on the American Academy of Allergy Committee leadership for nearly a decade. She is a clinical assistant professor at the University of Toledo College of Medicine, and she is also the visionary behind the ILIT Learning Network, which I have been a member of for well over a year and continue to be a member of. And really, it's this awesome, groundbreaking initiative, really connecting clinicians in the pursuit of better allergy care for our patients. Beyond medicine, Dr. Patterson is a wife, a mom of 4. She is a believer in the power of adventure, and whether that's spending time with her children, unwinding at the lake with her husband, or exploring the world one passport stamp at a time. So thank you for joining me, Amber.
Thank you so much, Kara. It's such an honor. You're an incredible physician, and I feel like what you've done with, really finding a way to listen to what patients need and shining a spotlight on that and being a kind of a light, I would say, for those who don't feel that they're being heard by their physicians. In that way, the student has become the master. So thank you so much for inviting me.
Thank you. I think it would be helpful. We have a mixed group here today. We have some of our colleagues here that have joined. We have some patients. And, let's start kind of with some of the basics. Like what is allergy?
So I guess I would say allergy is a type of immune dysfunction. We all have an immune system that's incredibly complex and beautiful and works in all kinds of ways at every minute of the day to keep our body healthy and safe. And sometimes parts of the immune system don't work the way they're supposed to. And allergy is one of those not working the right way. Essentially, with allergy, it's when our, people that are predisposed to allergy, their bodies develop antibodies against things that are a normal part of our environment, whether that be grass pollen, dog dander, peanut, things that when you're normally around them, you should be just fine. But people with allergy aren't just fine. They have symptoms that cause inflammation and discomfort that can affect quality of life and in some cases be life-threatening.
Yeah. And how big of a problem are allergies?
Allergy is like this big black hole. What kind of allergy are we talking about? Are we talking about environmental allergy, food allergy, drug allergy? But I think if we look at environmental allergy, which is probably the, pop culture thing that most people are talking about this time of year with pollen counts increasing, there's up to 40 million Americans that suffer from environmental allergies. So it's a pretty significant group of people.
Mm-hmm. And I think, from our training and what we've learned over time too, is that number has increased and the severity of symptoms and how it affects people has worsened over, the preceding 50 or so years.
And that's such an interesting thing to think about too, because there's a few different things contributing to that. So there's this idea that there are more people developing allergies. And that kind of goes back to this hygiene hypothesis concept that our society is becoming cleaner and cleaner. And when you think about the use it or lose it mentality, our immune system's the same way. So if when we're babies and little children, we're not out on the barn floor interacting with the animals and all the different microbes that are out there, our immune systems aren't getting that practice of how to determine self, not self, good, bad. And so it goes a little haywire. There's, concern about our vitamin D levels and antibiotic exposures and all kinds of things that can contribute to, are more people developing allergy? But then there's also the concept of how our environment is changing. So we know that with climate trends, that certain parts of our world are getting hotter and hotter. And so as we map what that means for plants and pollen production, there are certain parts of the world, like where we are in the Midwest and into the Northeast, that are going to see increasing temps and significantly increased pollen counts, more pollen being produced, stronger pollen for longer periods of time. Then there are places that maybe they're already really hot, and as they get hotter, those plants are just going to die. So their pollen counts will actually go down. So it's interesting to look at all the different factors at play with how are we developing allergy? Why are we developing more allergy? And for people that have it, why is it getting worse?
Yeah, I think, there's been this term and kind of discussion in many health circles about figuring out the root cause of what's going on. And I really increasingly am calling out that it's not just one root cause. It is this perfect storm of things that's going on. And it's a storm of driving factors that we really need to think about. And then also take that and reconcile it with, okay, that may be the case. What are those? But also, what can we do about it? What do we have the bandwidth for? What makes sense, and what's going to move the dial the most? So I guess when we think about how we were taught to treat allergies, I was wondering if you could explain a little bit about kind of that approach that you and I learned about, and how that's evolving.
Sure. So we use kind of a three-pronged approach when we're discussing with patients how to manage your environmental allergies. One, see if you can modify your environment based on whatever the allergen is. So we'll use grass pollen as an example again. If you're allergic to grass pollen in Ohio, where we live, May, June is a really bad time for grass pollen. That time of year, you want to keep windows and doors closed. Use air conditioning at home if you need it, in the car, at work, wherever you can control that environment. Things like if you've been outside all day, when you come home, shower before you go to bed. Different ways that you can reduce that exposure to allergen. The second thing is medicine. And we know this is a Band-Aid, but sometimes you feel really bad right now and you want to feel better right now. So we talk about, okay, well, what are some things over the counter, prescription, oral, nasal? What are different things that we can use to be comfortable, to get a good night's sleep, to make it through that presentation you have to give at work? And that's where medicine has a good role. That's not something we want you to be on for the rest of your life. So the third thing that we can do is therapy. Allergen immunotherapy is this incredibly wonderful medical tool that we have where we can retrain your immune system. So what if your immune system has gone awry? Let's bring it back to where it should be. And with immunotherapy, we introduce small amounts of exactly what you're allergic to back into the body, gradually over time, teaching those immune cells, hey, this is actually an okay part of our environment. We don't have to cause all this inflammation. So eventually, as the inflammation decreases, your response to being around the allergen decreases, we can get most of our patients off medicine, or at least on a decreased amount of medicine to a manageable amount. So the traditional way of doing allergen immunotherapy, which colloquially is kind of referred to as allergy shots, sometimes we call it by the medical term subcutaneous immunotherapy, or SCIT, for those in the know, and now you're all in the know. So with SCIT, we do that injection of the allergen just under the skin, usually in the upper arm, just under the skin of the arm. And when you think about how that process works, you're injecting this small amount of allergen just kind of into the subcutaneous space. It's almost like, I liken it to, if you're planting a garden. If you went outside and just tossed a bunch of seeds into the field, you probably wouldn't get very far by doing that just one time, because When we put that allergen there, antigen presenting cells or other parts of the immune system have to find that allergen, grab onto it, carry it to the nearest lymph node, and present it to the cells that are going to do the retraining, your lymphocytes. So we do this many, many times, week after week after week, month after month, injections in our office. It works well. It just takes time. It can take a year before you're noticing improvement. Many people need 5 years of treatment before we can attempt stopping. And so when we developed this newer way of treating allergies, ILIT, we found that when you take that allergen and deliver it directly to the lymph node, we use ultrasound guidance to make sure that the injection goes right where it needs to go. It's just a more efficient process. It's back to that gardening analogy. It's digging a hole in the ground and planting the seed and covering it up. You're going to have a much higher yield when you're very intentional and precise about where you're putting the antigen or the allergen. And so because of that more efficient process, with just 3 injections, 1 injection every 4 weeks, over 8 weeks, you can complete the entire process that normally takes hundreds of shots over 5 years.
So I love this story because I've heard you tell this story before, but what initially drew you to exploring this specific approach? And like, take us back.
So, Kara, I was sitting in the education building, first floor at Nationwide Children's, where the allergy fellows used to sit. But I was nearing the end of my fellowship and I had plans to move back to my hometown where I live now and start a practice. And one of our faculty members, one of the newer faculty members, had abruptly had to move back to where she was from. And so it left this hole in the faculty that they generously offered that I could interview to stay for that position. And so I was sitting in that area, preparing for my interview, just dreaming about how am I going to make this world a better place with what I'm doing with my career? Like what can I study? What can I do? And I already just loved the concept of immunotherapy. I mean, I know everyone who's an allergist loves immunotherapy. That's part of why we become allergists, aside from loving immunology. But I just thought even though immunotherapy has been around for over 100 years, there's so much more to learn. So I'm sitting there thinking all of these thoughts and happened to have a journal, like a medical journal, sitting in the cubicle and started flipping through that. And I came across the first ILIT study in humans studying allergy out of the University of Zurich that Dr. Kundig and Senti had published. And I was reading it and my mind was just like, it was so well written. It like held your hand walking through like, this is how we do allergy shots now. Let's see how if we do that versus if we do this new way ILIT, how that turns out. And it showed excellent results. People that got ILIT in just 3 injections were doing just as well as the people who are getting SCIT over 3 years. And so I thought, wow, well, this is the future of allergy shots. And no one's doing that in the US. We're not even teaching about it in fellowship programs. So I walked into that interview and I said, I want to be on faculty so that I can research intralymphatic immunotherapy and change the way we do allergy shots. And guess what, guys? I got the job. I'm so grateful for our division head and section chiefs at the time, Dr. Octavio Ramillo and Becky Scherzer, Peter Mastillo, Elizabeth Irwin. They were all so supportive in taking this new faculty member with this new idea and literally doing anything they could to support me making that happen. So that was kind of the start of it. I connected with Dr. Kundig and his group, brought him over to that lecture that you were actually
I was trying to remember if that was 2013 or 2014. And I was curious if you remembered.
It could have even been 2012.
Okay.
Maybe 2013. But
I think I still was in residence. That's what I was trying to remember. I think I still was a resident, but I already had known that I was going to do allergy, which like that narrows it down a little bit. When I learned about it, that was my first exposure, was that lecture by Dr. Kundig, which is essentially covering what led up to that paper and that paper's results. And I had that same, mind blowing, like, one, on the science, but two, I think it also really shook my world in kind of, I still had a little bit of like that innocence still of like how things worked and like that people were ahead of profit. And I think that shook things up a little bit. And I guess kind of what I'm alluding to, and maybe you can share, is, I think one of the questions folks ask me is like, why, if this treatment is so great, why aren't we seeing it everywhere?
Mm-hmm. Yeah, I mean, that is a lot to unpack. I think, first of all, think about like, put yourself in my shoes, new faculty member wanting to bring ILIT to the US. No one's doing it. There's so many questions people ask, like,
And rightfully so.
right, like, are patients going to let you do an injection in the groin? Or, because that's where it's done kind of in the upper thigh, hip area. Is this, can we do something that's not FDA approved, which it actually is off label, which is a generally accepted way of doing things. But that's why I was so grateful to be where I was at that time and place, because with everything there was at Nationwide Children's in Ohio State, we were able to do things what I would say is the responsible way, the right way. So we filed an IND with the FDA. We said, here's what we're going to do. We had to figure out, extracts in Europe are different than in the US. What are we going to use? How are we going to dose this? What's safe? What's effective? I designed the first clinical trial in the US, and we were the first in the world to use this in pediatric patients. So there was a lot of figuring things out, but in a responsible and as much as research-based way that we could kind of keep it going. But you're right. There was feedback from other allergists like, oh, so, if people only need 3 shots and then they don't need us anymore, well, allergy shots are half of our income. We're going to go out of business. And so there was a lot of kind of just convincing people, really, let's look at how many people could benefit from allergy shots versus how many people actually do them. It's surprisingly a very small percentage. Different things are appropriate for different patients. And so being a way to say our traditional allergy shots are an excellent treatment that are still, important and an important part of practice. And also having ILIT available for people who otherwise will not come to your office for shots is meeting the patient where they're at. So I think as a group of allergists, immunologists, and tell me kind of your perspective too, Kara, but I feel like we've really grown. I feel like allergists are getting on board with this and understanding that we can't just keep going the way we were with having only one option for patients. We have to move forward and keep advancing the science.
I think I saw that tide change happen very early in my career. So one of the stipulations for my faculty job when I joined Ohio State was and it was written into my contract that I would take over the sublingual immunotherapy program. So one of the other ways that we're able to do immunotherapy are placing those allergens under the tongue, either there are several FDA approved tablets that back then were still in trials, or using the same extracts we would use for shots, either SCIT or ILIT, but putting that in a solution under the tongue. And back in, let's see, this would have been 2016, 2017, when I was going onto faculty, majority of that sublingual practice was being run by ear, nose, and throat doctors. And, frankly, was a decent amount of animosity between folks who were trained through the pathway we were trained and those ear, nose, and throat docs who were practicing allergy. And I was instructed to be hush-hush about the fact that I was taking over that practice. Interestingly, now that tide has shifted, and I have folks reaching out to me to ask them how to do sublingual immunotherapy because they've realized, again, we have to meet people where they are. Not everyone wants to be poked. Not everyone can come into the office every week. Some people, traditional allergy shots are essentially kind of too strong. They have too many reactions to them. And so sometimes with liquid, you can really dilute things down to much lower levels. And so I think that essentially kind of helped at least get that momentum of people like, oh, we don't always have to do it the way we've always done it.
Yeah, there are other ways. I think the other thing that, well, I'll just say I'm really proud of you and the rest of our learning network, because I think what we're doing, creating this network of allergists who want to be doing ILIT and want to be offering it and doing it in a safe way, coming together so that we're practicing in the same way, but also able to learn from each other, is really powerful. So it's, you know how things go. First, when something is out there that's new, no doctors are doing it, no patients really know about it. But the more people learn about it, you're going to have more patients wanting it. And then you're going to have people just kind of picking up, trying to figure stuff out that may not be the right dosing, the right, considering the right safety measures, the right precision of technique. And so I think the fact that you are an ONI ILIT certified allergist-immunologist says a lot about the program you're developing and offering to patients. And we are going to be able to offer a better quality.
Yeah. So Bridget is the head ultrasound expert that Dr. Patterson has worked with, years and years of experience. Together, they do the hands-on teaching, but technology has allowed it so that if I'm having difficulty finding what I think's, an acceptable target for the injection, I can just hit a button and boop, 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 Bridget's able to come on and use her little pen and go, yeah, that is a great spot. Go for it, and like watch it right there in real time, which, that's pretty amazing.
I think so too.
Yeah.
And you know that with ILIT, precision of injection is so important for safety and efficacy. So the fact that we have our whole network and Bridget to lean on is really, to the benefit of our patients.
Gosh, we could just go on and on. I think this will be a great ongoing topic for our future thing that we're going to share at the end, a little teaser. So make sure to stay till the very end because we have some fun announcements. But is ILIT considered kind of out of trials? Is it still considered experimental? This was asked by someone who also has some other underlying health issues like mast cell and some autoimmune issues. So kind of wondering what makes someone a candidate and is it experimental?
So I guess regarding the experimental part, so with treating environmental allergens, the extracts that are used are FDA approved for injecting for treating allergies. So we are using it off label by just injecting it in a different way. So that's kind of the term you use. Why is it not FDA approved for ILIT? That's really probably more of like a business thing.
Oh.
The companies that make our allergen extract would have to invest in taking that through the FDA approval pathway. And with some changes that occurred about 5 years ago, a pathway that was previously more financially reasonable for allergen extract now considers allergen extract to be a pharmaceutical drug. And so that means even just like initially applying is millions of dollars. So hard to say if any of the manufacturers would ever take that on. So that's kind of the reasoning behind why is it not FDA approved for ILIT, but it is off-label. Who's a candidate? Well, if you have allergies and you are a candidate for immunotherapy in general, meaning you've got symptoms that correlate with positive test results, you either don't want to have to be on as many medications as you are, or want a non-medication treatment, or just want something that's not a Band-Aid. You want a long-term treatment option that's going to make you feel better without needing continual treatments, you're a candidate for ILIT. Some of our patients that I feel like have really gravitated toward ILIT over SCIT are people that don't have time to come into the office. So we have business folks who travel a lot and their time is very limited. We have teenage athletes who maybe they're practicing multiple hours a week, multiple nights out of the week, and they just don't have time to get into the office during our office hours either. I live in a rural area. We have farmers who they don't want to leave the farm. So if they can come 3 times instead of 100 times, they're down. Who are some patients you've talked to, Kara, that you feel like?
Knowing my practice, right? I have a significant number of folks with autoimmune diagnoses, or we suspect that, and with mast cell activation. And I know you have a particular patient or a couple of patients with MCAS that you've treated that we've talked about offline.
Yep, I'm glad you brought that up, because that is a population of people that are highly sensitized.
Yeah.
So small amount of exposure to something that to a person without MCAS may have some mild to moderate symptoms. Somebody with MCAS may have severe symptoms. So ILIT's a great option for them because the dosing is much lower and it's just fewer contact points. It's only 3 injections that you might have a reaction to instead of 100. So,
yeah. And I think, one of the things that I found so fascinating off the bat is that there are very few to no mast cells within the lymph node tissue. Like it is not a space where they are in as robust concentrations as what you see in our skin. And certainly you need to go through the skin to get to the lymph node. So it's not without risk. There is some risk, but it is lower than kind of what we think with that subcutaneous or just under the skin tissue, which is where those mast cells are located.
Exactly.
Yeah. I had a quick question that came up in our group, Dr. Patterson, which was, what has been your experience on people who've been on shots for several years and stalled out?
What do you mean by that? Like they didn't...
If they've been on ILIT, how has that gone?
We see really good results there. I have so many patients who come to me and say, I did 1 year of SCIT or I did 2 years of SCIT and then this, that, or the other happened. I moved. I had a reaction that they said I couldn't continue. Whatever the reason, those patients do really well with ILIT because it's a shorter course. It's a more targeted approach. And it's definitely something to consider if you haven't been able to complete a course. Now, kind of along the same lines, I've also had we know patients that complete a full course of immunotherapy may need another course down the road. So I've had patients who 20 years ago had a course of immunotherapy that worked really well for a long time. Now their symptoms are back. This time around, they don't want to do the 5-year thing. And they, maybe they're 65, 70, 80. They don't know if they'll be alive. And this came up in our breakout session after a 5-year course. So definitely something to consider if you've tried SCIT before or even SLIT and it just wasn't a good fit.
Awesome. Should we tell folks about what we're planning to continue this conversation?
Yes.
So Dr. Patterson, myself, and our very good friend, Dr. Megan Shepard, we have been friends for, over a decade and are all allergists together. We're all part of the ONI Learning Network. And what we realize is that there is not a great centralized hub for allergy education on YouTube. So we are meeting up in, about 2 weeks and recording our first episodes of
Allergy, actually,
which we're very excited about. So if you have any suggestions on topics that we talk about, your burning questions about allergies, about allergy treatment, myths or misconceptions you've heard, this resource is for you to learn about the science, to learn about, treatments, options, all of it. And we're excited to have a really fun excuse to hang out together and share the information and recapture some of the magic that we've had when we get to meet up at meetings and over these years. For this event, this monthly event, next month, we are really excited to welcome Dr. Jill Kraft, who is actually from Tampa. We had some folks from Tampa joining us today. She is a internationally recognized expert in women's health and in particularly vulvar conditions. And that's something that comes up a lot when we're talking about our immune system, interestingly enough. And also, we don't always feel comfortable bringing up those topics when we are in our allergist or immunologist office, right? We often think of that as confined to our OBGYN's office. Now, Dr. Kraft is OBGYN trained, but there's immune system everywhere. And so really excited to talk with her to learn from her. And yeah, so that's coming up May 23rd, tentatively, again, 1:00 Eastern time. So look for that. And in the meantime, we're going to respect everyone's time and let Dr. Patterson get on to the rest of her Friday and weekend. Thank you so much.
Thank you, Dr. Wada. You are changing people's lives. Your patients are so lucky to have you. And I just am so excited to see where you're going to go from here, because you're helping people big time. Thank you.
Thank you. And I'll see you in 2 weeks for sure.
Bye.
Bye.